My shyness, my misunderstood.
Howdy, Ags. Welcome back
My destiny
to Exercise Biomechanics, where we've got another day of action. Today I went, well, a little long yesterday. So today's going to be a shorter lecture. So we're going to hold it to just under around an hour or so. And the topic, again, will be bone biomechanics. We're going to be focusing on the changes that we see with aging as well as development. So mechanical properties of bones in children and older adults is much different than young adults. And these are the two populations which are most susceptible to fractures as we look throughout the lifespan. So we'll talk about what's unique about each, and we want to contrast aging with development. Sometimes people get them mixed up. Development is basically growing up. These are genetic programs that help you to develop your muscles, brains, everything you need to be hopefully a good functional adult. And this process takes in humans about 16 to 18 to 25 years, depending upon the tissue. Usually the growth plate fuses at about age 15, 16 for young women, and about 17, 18 for young men. The brain's about fully developed somewhere around age 25 or so. So different tissues have a little different timeline. For bones, we reach peak bone mass in the early 20s. And we still can actually enhance peak bone mass. So when we talk about development, we're going to talk about some of the changes that happen due to a transition from bone cartilage material to hard adult bone. And then the aging process is basically a deterioration that happens with age. We lose usually mass, we lose function of many different types of tissues in the body. We often have a trouble with coordination and communication. So there's a communication, in a sense, an information theory of aging, which to me is a pretty good one, because as we get older, our tissues, our cells get a little confused. Some of it's the environment that they're in. There's usually, in a sense, more junk, more waste products and partially oxidized proteins that we haven't cleaned up. Sometimes our hormone levels, key hormones like growth hormone, estrogen, testosterone are also decreased. So the environment decreases, and that affects the communication inside the cell and even between cells and between tissues. So we'll start today by focusing on the changes that happen in bone with the aging process. Now, I actually have to, I guess what's the best word? Limit or amend that thought that this is what we're going to see with bones in humans is true aging, because the latest literature over the last 20 years indicates that a lot of what we think of as a true aging process is really a combination of aging and sedentary lifestyle, aging with underlying chronic disease, heart disease. It could be metabolic disease like type 2 diabetes, etc. So all of these things do make a big difference in terms of deterioration that happens with age. But there's actually some thought that a lot of what we see, including with osteoporosis, isn't simply just true aging itself. Part of the reason we think that is if we expose stem cells in bones and muscles and in other tissues to a young environment, they actually respond as if they were young. So that's something that's actually encouraging. If we can make our environment as young as possible, then it's possible to increase our health span for a longer period of time if we don't increase our lifespan. Okay, so with that message, in bone up to about age 40, we can maintain osteoblast activity at least as high as osteoclast activity, as long as we don't overtrain, as long as we get a good diet with plenty of calcium, plenty of calories, etc. If there's an imbalance, then whether it's one way or another, you either build peak bone mass or lose bone mass. So one of the things we want to be able to do is build peak bone mass by age 20 and then maintain it to age 40 or age 50 even, we've seen with some athletes. So that's possible. Between ages of 40 and 50, men and women have a similar loss in bone mass and bone density. Some of this may be long-term sedentary lifestyle. There could be underlying chronic metabolic diseases, cardiovascular disease, etc. And then after age 50, we see a marked reduction in estrogen after menopause in women, which would be between the ages roughly 50 and 55. And then in men, you have slowly decreasing testosterone levels. They start to decrease technically at age 30, but they start to decrease more rapidly after age 40 and 50. Women may lose up to 50% of cancellous bone. That's a lot. And that's the bone that gets targeted with osteoporosis. Men may lose 25% of cancellous bone. So that's what we're trying to do. We're trying to reduce the risk of osteoporosis. We think that at least some of this is preventable. Healthy lifestyle, including physical activity, good diet, can go a long way. So what we're trying to do is prevent these osteoclasts from chewing up too much material. Their activity and the number of osteoclasts themselves increase with aging, particularly in women and in men when estrogen and testosterone levels decrease. I should also mention that growth hormone levels also decrease, and that would decrease the amount of insulin-like growth factor, or IGF-1. Okay, so the material properties, because that's really the health of connective tissues, they also decrease. Strength decreases about 4 to 5% for every decade. We don't think there's much of a change in stiffness with aging, especially in the elastic region of a stress strain curve. So the bones are still pretty hard and stiff, particularly the cortical bone and the shaft of the bones. The strain to failure, that's a thing that changes big time. The ability of bones to be able to undergo a great deal of strain decreases markedly. So on the left side, this is a marker of ductility. This is decreasing, you can see, pretty steadily over time. In fact, by the time we get to 75 or 80 or so, it looks like it's decreased about 40, 50%. So that's quite a bit. And here's, oops, I don't know how that happened. There we go. Here we see strength being decreased with aging, and you also see the strain to failure decreasing as well. So bones, when people get older, lose ductility, they get more brittle, they lose strength. And on the right side, this is a marker of toughness. You can see in someone who's older that the toughness is down about 60% compared to someone who is young. So that's a huge difference. Strength, ductility, toughness are all decreased. That means the bone is much more likely to be injured. When it's injured because it's brittle, that bone is more likely to suffer shattering. And that means it's very difficult to repair, especially in an older person. The common sites of fracture in the elderly, which are the common sites of osteoporosis, are cancellous bone at the neck of the femur. So that's a hip fracture. The thoracic vertebrae in the middle of the spine. There's actually the greatest amount of curvature just before the lumbar spine and at the end, very beginning of the thoracic region compared with the cervical region. So cancellous bone is more affected. So we're talking about the neck of the femur, the vertebral disc, not vertebral disc, the vertebrae, again, the beginning of the thoracic and endothoracic region, and also the distal radius of the wrist. So those are the three most common sites. With cancellous bone, the bone becomes a lot less dense, and it reduces its ductility because of changes in geometry. The trabeculae, or little beams that are laid down, you can see we start losing a lot of these with aging. And that makes the material not only weaker, but makes it a lot more brittle. That's the big thing that happens with the loss of trabeculae. The number of cross beams and the thickness of the cross beams, both of these decrease. So huge difference. Okay, next slide. There we go. With cortical bone, there are also some changes. The cortical bone does thin as people get older. That seems to be more true in women than it does in men. But there is something good that happens with both development and aging. With development, we get an increase in mass. And what we're looking at here, this is a cross section, so that's why you're seeing these rings. This is the periosteal ring, that's the outside of the bone. And then you have the endosteal ring, that's the inside. The medullary cavity is in the middle. It's filled with red marrow in children, yellow marrow in adults. During development, until you're in your mid-20s, you see the periosteal ring growing, but the endosteal ring also grows out. There's a lot more muscle mass, so mass is increased. But what's also increased is the radius of gyration, the distance between the axis of rotation and where the center of mass is in two directions, or two dimensions, I'm sorry. So this basically represents like a donut. So the donut has mass, the middle is hollow. That increases the moment of inertia. So remember, moment of inertia is the resistance against torque, but it's also the resistance against bending forces. It's also the resistance against bending forces. So that's a protective mechanism. With aging, as people grow older with cortical bone, you do lose mass, no question about that. But the radius of gyration actually increases more. And since the moment of inertia is proportional to the square of the radius of gyration, so I'm afraid, yes, there'll be math still, that means that, let's say if I double the radius of gyration, the moment of inertia is quadrupled. So if I reduce the mass in half, it's still doubled. So what we're saying is that the movement of the mass away from the center or longitudinal axis of a bone helps to counteract some of the reduction in mass. It doesn't mean that cortical bone in older adults is going to be safe and you're not going to get a fracture there. It can occur, but most likely when a fracture does occur, it will be in cancellous or trabecular bone. Okay, we want to contrast in children during early development because the bones are made of ossified cartilage. It's soft, it's not as stiff, it's not as strong. There's a lower energy to failure. So that's toughness. I was going to edit that on the run, but I won't be able to do that. Things aren't cooperating, but that's okay. Toughness is decreased. But you do have a large strain to failure. What does that mean? That we have a large plastic region in the stress strain curve. So when a fracture occurs, it's likely to be a partial fracture. We sometimes call this a green stick fracture. Now that can be a problem every once in a while because the fractures sometimes can go across the growth plate, and that could inhibit growth later on. So I had a friend named David once upon a time. And we were actually in a pool area, and the pool was closing down, and we were about 12 or something like that. So David says, "Well, no one's around. Hey, let's go in the girls' bathroom." I'm like, "Why?" Okay, so we go in the girls' bathroom, and he sees some female apparel up on top of. There was a cinder block wall, so he climbs on top of it, grabs the apparel. But at the same time, he accidentally grabs one of the cinder blocks. It breaks loose. It lands on the distal part of his tibia, and he fractures the tibia. So back then, they put him in a huge cast, like up to his knee joint. It was ridiculous. It was so heavy. You needed a wheelchair, or you needed to get around in crutches. But his dad felt sorry for him. He was a football coach and took him deep sea fishing. And so he and some buddies, David put a line out, and then he caught something because they were after like big game fish. So they caught a blue marlin. It wasn't just, you know, your average 100-pound blue marlin. It was a 444-pound blue marlin. David had only saved enough money mowing lawns to be able to stuff the head. So he did that and put it on the wall in his bedroom. So so the good and good and bad news today, David, I think still has that stuffed marlin head, even though I think his wife made him either put in the attic or somewhere for the most part out of sight. And I don't really feel that sorry for him, because even though the fracture went through the growth plate, so he's about half an inch shorter on one leg than the other, but he's 6'2.5" on his left leg and maybe 6'2" on the other, so not that big a deal. But all kidding aside, that can be a problem, especially in terms of hand movement and foot movement and getting around and having a good gait, etc. Bone maturation, one of the things we see with this is really interesting. We call it sometimes ontogeny. We see a transition from initially fibrous material to bone cartilage to eventually hard bone at about 16 to 18 years of age. This 18-year or so plus process is recapitulated, meaning we go through the same thing with a fracture healing. We actually see fibrous material, soft cartilage, and then hard bone. And that process takes 2 or 3 months. So when we talk about bone fractures, and especially in young adults, we're going to see that. Bone development, we want to, as part of primary prevention, to reach a higher peak bone mass. So the way we're going to do that is exercise and good diet are part of primary prevention. They're also part of secondary prevention. But during development, we do want to watch over training, but we do need regular exercise before and after puberty. They will reduce the risk of osteoporosis. There's something really interesting, though, about the effects of exercise on bone mass, especially in developing people. We think it's almost like rings in a tree, that you accrue a little bit more bone mass with each year of physical activity and good diet. And the effects are systemic, unlike the effects of exercise on bone in adults, which is very specific to the site that's loaded. The site that's loaded certainly gets benefits, but the rest of the body does as well, as long as that person continues to exercise during their adulthood. So you can build even more peak bone mass and maintain it systemically for a longer period of time if you continue to exercise. So that's why it's really important with physical education, with activity, with youth sports, with staying physically active, that it's important to people think about this as a lifelong commitment, or better said, a lifelong way to have fun, to get your energy out, to be able to get into shape, to reduce health disease risks, including osteoporosis. Keeping up, especially in your 20s, 30s, 40s, and 50s, especially including the 30s and 40s and 50s. They're critical because they will set the stage for your health span as you get older. And that's going to be incredibly important, whether we're talking about tendons, ligaments, bones, muscle, your cardiovascular system, brain function, everything. So in this case, there's been a few studies, one that's been done with tennis players, another one that's been done with, I think, baseball, softball throwers, people who throw in their dominant arm. They actually have a significant increase in bone mass, and that's maintained if someone continues to exercise throughout their lifespan. So really interesting data. Usually these effects of mechanical loading are very specific to the site that's being loaded. So if you're doing a lot of elbow flexion exercises and military presses, ordinarily they're not going to help you be a better soccer player. but you could have some effects on bones all over the body because of the exercise that you're doing, whether it's upper body or lower body, in someone who's young and someone who's a child. And that can be maintained, that advantage, throughout the lifespan if you continue to exercise. Okay, so we're going to get to some critical stress strain curves and talk about what they mean. We're first going to look at development from 10 years of age to 20 years of age. So in a 10-year-old has mostly ossified cartilage. That bone is soft, it's not as stiff, so that means the slope of the line is decreased. The strength is also down, as you guys can see here. But the other thing that's going on is that the strain of failure is actually greater. So that means that that bone is actually more ductile. So if there's a fracture, it's likely to be in this plastic region, which is really long. And that's why in kids, you see a lot of green stick fractures. So one of my brothers got a green stick fracture playing football in the backyard with a neighbor's house. Neighbor threw it to him, and he had the ball in his hands and crashed into a pine tree and had a bone fracture of the clavicle. Not unusual. It was a green stick fracture. They just put him in a sling even back in the day. So that was much better than being put in the cast. They still used to do that sometimes. Okay, so bones are softer. They're not as strong, but when they fracture, they're more likely to have a green stick fracture in young kids. With aging, though, in that process, the stiffness doesn't change a lot, especially in cortical bone, but strength is decreased and the strain of failure is way down. So ductility is impeded, brittleness is way up, so the bones get a lot more brittle, they get weaker. If we look at the area under the curve, which is the energy that can be absorbed and the toughness, that bone from a 70-year-old is not nearly as tough as from a 20-year-old. And that's why they're more susceptible to fractures. And when you combine them with shear forces, you have the chance, because the bones are brittle, to really get those bones might shatter and they might splinter, and it's going to be very difficult for them to heal, whether it is a hip fracture, which is in the neck of the femur again, or the thoracic vertebrae, or the wrist. And that's where most fractures happen in people who are older. Bone injuries. Oh, I should mention that I've been updating files as I'm going. So I have new PowerPoint slides files for stress and strain, mechanical properties, mechanotransduction, skeletal muscle mechanics, bone mechanics, etc. So I'm updating these as I go, and hopefully I'll be able to update the tendon and ligament and cartilage a little bit, probably not as much as the bone and skeletal muscle, because we'll have exams to grade very, very soon, and that could take a while. We'll see how that goes. Bone injuries. So these are fractures for the most part. A traumatic fracture, it means a single event, low frequency, very high load. They often include unusual types of loads, and we mean shear for the most part when we see that. Combination load, shear, bending, torsion, compression, you combine those, all that could happen with a skiing accident, for example. You could get a nasty displaced fracture. Material fatigue injuries. This happens with repeated loading, very high frequency, but only moderate intensity. And a number of factors can be at play here. Nutritional hormonal factors increase the risk of a stress fracture occurring. You can have a low calcium intake, low estrogen levels in women. Stress fractures are overuse fractures. It means that you have micro trauma that accumulate over time. Under a x-ray, you'll see something like a stress reaction. That's actually a milder form of a stress fracture. It's hard to actually see except a disruption around the periosteum. That's usually a first clue. We can also do nuclear bone scans to take a look at what happens with a stress fracture. with a nuclear bone scan, the area that's trying to remodel fastest, is trying to repair itself fastest, gets a hot spot. And based on palpation, based on symptoms, maybe the x-ray, they'll see maybe a periosteal reaction. They'll say either a stress reaction or a stress fracture. We go back a second. So that's one type of bone fracture. Some of the different types of bone fractures are related to what type of load or force or stress actually caused the fracture. An avulsion fracture can be caused by either a ligament or a tendon pulling a piece of bone out. This is a fracture of the fifth metatarsal. This happens to basketball players and volleyball players occasionally, where a tendon will pull a piece of the fifth metatarsal actually out. You can even see them in the biceps brachii. So very occasionally, an avulsion fracture will happen to like a skydiver. And usually, but not always, it happens in someone who's younger, and that's because tendons and ligaments are actually stronger in tension than bones are at that point. Later on, by the time you're 25 or 30, usually the chances of an avulsion fracture will be a lot less. And therefore, the injury will often be to the tendon or the ligament rather than the bone. But they can occur in young and middle-aged adults as well. Okay, with a spiral fracture, a large, and this can happen like with skiing, you get this spiral fracture that happens with large torsion or twisting. So anytime you see like a corkscrew appearance in the fracture, that's telling us that we've had high levels of torsion. What the high levels of torsion do is cause very large shearing forces right in between the areas that are being twisted apart. Impacted fractures are usually with high compression, comminuted. So technically this would have compression and shear forces on the inside. This can happen in the lower leg. It can also happen in the spine as well. So the type of fracture that we see in the thoracic vertebrae is a little bit like a comminuted fracture. Because the material is pretty brittle in an older person, the chances of losing some bone mass in the spine is actually high. And that's usually what happens in the spine, is you sometimes have repeated fractures in the thoracic region that can result in eventually Dowager's hump. So as we mentioned, green stick fractures are partial fractures. They don't go all the way through the bone. The bone maintains some of its material properties. The healing time is considerably less, so that's some of the good news. Again, with a material fatigue injury, these are overuse injuries. Nutrition can play a big role, meaning if you're not getting enough calories, not getting enough protein and calcium, then the risk of one of those injuries is much higher, especially because sometimes in women and even in men, they can cause androgen hormone problems. Estrogen, testosterone levels can drop. Okay, minimizing the risk of a stress fracture, or frankly, any kind of fracture, wearing proper equipment to reduce the loads and increase the cross-sectional area or contact area. Be careful exercising when fatigued or tired or when your muscles are weak. So this happens with delayed onset muscle soreness. Avoid coming back too soon after an injury. Off-season training. Sports today are all year-round training. And a lot of the off-season training is technically preparing bones, tendons, ligaments, cartilage, and bone and muscles for the upcoming season. So that can take a number of months, 3 to 6 months of conditioning during the off-season. That's incredibly important. And that extra 10 to 20% in terms of strength or toughness could mean the difference between a debilitating or season-ending injury, orthopedic injury the next season, or no injury whatsoever. Avoid switching sports without proper training. This sounds a little weird, but let's say, for example, someone's a swimmer, and that's usually a winter sport. The loads, for example, on the spine and on the legs is much different in running than in swimming. So let's say you're going to translate from swimming to maybe track. So when that happens, during the transition, the potential of a stress fracture is possible. So one of the things that you should probably do, and swimmers often do this, is do some resistor training during the season, and especially during the transition to track. So depending upon the sport, you have different types of loading. You might take occasional days off. Connective tissue takes a little longer to repair. It takes about a year or so to replace a lot of the collagen in tendons and ligaments and bones. Bones may take up to 7 years to replace every piece of material that's in your femur or tibia. So now you're probably technically on like your third your third version of your tibia or femur, your bones. And I'm on a lot of generations. We won't even talk about that. Start slowly when initiating training. If you have a fracture, have an injury, what should you do? The good old Rice method: rest, ice, compression, elevation. You're going to get some inflammation. That's actually not completely a bad thing, but you probably want to maybe tamp it down a little bit in the first few days when it's really uncomfortable. And then you want to get in something like a boot that will protect the area from re-injury while allowing you in time to do range of motion exercises and eventually strengthening exercises. During the rehabilitation process, sometimes at the beginning, we might take non-steroidal anti-inflammatory drugs just because of the discomfort. They're inhibitors of cyclooxygenase, especially COX-2. There's COX-1 and COX-2, and they certainly inhibit them both. But COX-2 is the one that really responds with inflammation. All of these inhibit COX-1 and COX-2, but each one has a different molecular structure. So depending upon the person, you may react differently. So some people do better with naproxen sodium, some do better with ketoprofen or ibuprofen. So find out what works best for you. But should you take it long-term during the healing process? Well, that's kind of debatable with bones and tendons and ligaments. There is some concern if you take them chronically that it could interfere with protein turnover and that healing process. So it's a little bit equivocal, particularly in ligaments. With therapeutics after a fracture, we're trying to restore normal function. So we want to set the fracture if possible. If there's a mobilization, we want it to be limited. So you want something like a soft cast. Reaching into my bag of tricks. There we go. There's the soft cast, which you could put, let's say if you have a wrist problem and you have a wrist fracture. I think my hand's a little bit my hand's a little bit too large to fit into this. But these soft casts, these are great because you can take them off. One of the worst things, and I was in a cast for a fracture to my ankle. It actually happened playing basketball, and we were playing against a guy named Rick Smits, believe it or not. Dale Brown at LSU. That was working on my master's degree. And Dale Brown was the basketball coach at LSU. And this is before he was able to recruit Shaquille O'Neal and Stanley Roberts and huge centers. He was looking in Europe and everywhere else. And so he was looking in the Netherlands, found this guy. And then after Dale Brown was done with him, he was playing a pickup game of basketball. And I tried to shoot it over Rick Smits. Ball almost went off, and it rolled off the rim. And I landed on someone's foot, and there was like a crack. It didn't hurt a lot. It was sort of weird. It just felt like really rubbery because I broke the lateral malleolus, and that is the distal part of the fibula. That's technically not weight supporting. So I continued to play for about another 15 minutes, and my foot felt like jello, and I looked down. It was the size of a cantaloupe. So I kind of took it easy, went in the next day, and they put a huge cast on me, a fiber, wasn't fiberglass, it was just a regular plaster cast It was, I think, a walking cast. So they put basically a rubber foot on the bottom. And I think I played volleyball in the thing. It was crazy. But anyway, one of the worst things about it was not only the atrophy of muscles, and I didn't know it at the time, bones, tendons, and ligaments also atrophied. And it takes those tissues about a year to recover from casting. Just 6 to 9 weeks of casting can cause 8 to 12 months or require 8 to 12 months of rehabilitation to reestablish normal mechanical material properties of, of the connective tissue. And that's even if they haven't been injured. You add an injury to it, and then that debilitation lasts for even longer. Anyway, one of the worst things about it, which again is a great thing about a soft cast, is it gets itchy. These casts get really itchy. And so you learn to take like a coat hanger and get it down there and scratch it. This is one of the great things about this. Plus, when it's time to do some range of motion exercises, flexibility, and usually they'll be passive at first. So this is a passive range of motion machine. Here we see a physical therapist or athletic trainer, some physiotherapist, for someone who's had a foot fracture, going literally through some range of motion and stretching exercises. This is going to be progressive in nature. This is why they get paid, because what you have to do is you have to hit the Goldilocks zone. You need these exercises to promote the healing process, to reduce the amount of scar tissue, to enhance blood flow, to increase protein synthesis. But you don't want it too high because then you'll cause a re-injury. But if it's too low, then it won't be effective. So you have to get it in that Goldilocks zone. Passive range of motion exercises, even continuous passive motion. This is a CPM machine. And then active exercises later on. And eventually you're building in intensity and repetition where you can resume normal function. And if you're a competitor, get back on the field to play again. So rehabilitation, its purpose is to increase blood flow. That's the first thing that has to happen, whether a connective tissue or muscle is hypertrophying, undergoing growth, or it's repairing itself. You need blood flow. Angiogenesis is like one of the first things that happens. Then you need the mechanical action of movement to try to protect cartilage as well as other connective tissue and get amino acids and oxygen or substrate to the tissue. We want to decrease scar tissue. Scar tissue binds to lots of tissues around it and reduces range of motion and flexibility. And we want to promote that healing process. So during the healing sequence, this sequence is going to be for a young person with usually a simple fracture or a compound fracture that's been set. So we'll assume a young, healthy person with good metabolism. We're going to go through really good rehabilitation. So first, there's an inflammatory phase. A hematoma forms. Eventually, a fibrous callus is going to start forming. The inflammatory period is an alarm period. It lasts about a week or less. And there are chemicals like prostaglandins, histamine, free radicals are released. Cytokines are released. Those are in pro-inflammatory proteins. What they do is they not only cause swelling and inflammation, and they get warm, and there's some discomfort, which is good because it kind of keeps you off the injured bone. But the purpose is to increase blood flow and start to stimulate growth factors that are going to signal and carry out the repair process. You're going to get a fibrous material, soft cartilage, which is kind of a fibrocartilage, then hard bony cartilage, and finally bone remodeling. So the inflammatory phase is going to set up the next two phases. That's going to be the reparative phase and then the remodeling phase. So we'll look a little bit more at the inflammatory phase and talk about what's actually setting the stage for the healing process. So believe it or not, white blood cells and platelets are both critically important in that process. They're helping to clean up and to fix broken blood vessels and to initiate angiogenesis, which is the production of new blood vessels, and also proliferation of cells. One of the interesting things in the bone healing process is we're going to start to proliferate a number of different cells, including fibroblasts first, then cartilage cells, and then finally bone cells like osteoblasts. So they're M1 and M2 macrophages. They initially come from the same source, and they can interact and go in either direction. The M1 macrophages, as well as the NK killer cells and the T cells, these are inflammatory cells that are going to be involved in the cleanup and tearing down. A lot of these proteins you see here are tearing down stuff. In bone, rank L activates osteoclasts. So the osteoclasts, you're going to chew up the damaged material. You actually want that, believe it or not. Then you're going to kick in those M2 macrophages. And if things are going well, some of the M1 macrophages, some of the M1 macrophages will actually turn into M2 macrophages. Now, the key about the M2 macrophages and the platelets is they're going to set the stage for repair by stimulating growth factors like platelet-derived growth factor, transforming growth factor. That's going to stimulate collagen production. In macrophages, we've got vascular endothelial growth factor. Platelets also stimulate VEGF as well through platelet-derived growth factor, which you see here. IGF-1, bone morphogenic protein. All of these are going to help with the repair process. The first thing that really happens is the vascular tissue repair and angiogenesis first. That's the production of new blood vessels. Once that's set, then we can actually start to produce more protein. So that's where IGF-1 and platelet-derived growth factor, that's where they come into play. Okay, so platelets, M2 macrophages are going to turn on these key growth factors that are going to build a new blood supply, proliferate cells, and heal the tissue. So that's why the inflammation is there. It's actually good for us if it spikes and it goes back down, because now it's going to trigger that process. If it goes up and stays up, then it can cause all kinds of problems. Osteopenia in bones can cause tendinitis, long-term tendinitis in tendons, chronic problems in ligaments. Plantar fasciitis is an example of that. In the reparative phase, which is next, there's a callus that's being formed. Initially, that callus is made of fibrous material, kind of like a splint. So it's going over the hematoma, and fibroblasts are producing that. It's really almost like a tendon and ligament-like material. And then we see chondrocytes coming in, and first they're going to form a soft callus that's made, it's like fibrocartilage that you might see in the menisci of your knee or your vertebral discs. And then eventually a harder callus, which is made of ossified cartilage, similar to the bones that you see in children, and finally adults. So this process takes 1 to about 2 or 3 months after a bone fracture, if things are going well. This process is again recapitulating what happens in the entirety of development, from in the womb to 16 or 18 years of age in a person. It's the same process, but it's just ramped up big time. And what we hope is with biologicals, et cetera, and you can see and imagine, hey, a good way to enhance the healing process would be the signal increases in VEGF, TGF-beta, IGF-1, platelet-derived growth factor. There's a number of approaches to do that. One of the most interesting approaches, there's a guy named Steve Welk who worked at UCLA. We tried to hire him. I mentioned him briefly. Shout out to Steve. He's up at Indiana University instead of here at A&M. But he was actually using macrophages as, in a sense, a drug delivery system to enhance growth factors, which would be perfect if you want to heal tendons, ligaments, bones, or muscles that have been injured. So that's kind of a really unique approach, basically hijacking the immune system and using it in a way to enhance the healing process. So as we learn more about this could be one approach to basically recover from sports injuries. It would be pretty amazing after a class 2 sprain of a knee joint or of an elbow or your ankle to have you or your favorite player be back in like 2 to 3 weeks. It may happen someday, maybe less than a month. Normally, that would take about 6 months or so, 3 to 6 months to really get back to anywhere close to 100% or finish the season. So those are tough injuries to get over. If you have, for example, a class 3 sprain, which is a full tear of a ligament, we might be able to see someone come back in maybe 4 to 6 months instead of 9 months to a year. So hopefully that will happen. So the callus basically goes through this morphogenesis from fibrous material to cartilage to hard cartilage to hard bone. And during that remodeling phase, that's the last phase, you're going to see the callus shrinking and you're regaining the strength and stiffness that you had before. In fact, it's usually going to be beyond that. In this remodeling process, here they're showing the callus is not being any thicker. Usually most people retain a bit of a callus after a bone fracture. So in my left iliac crest, I still think I injured this wrestling when I was 16. I still actually have a little thicker bone than my right iliac crest. That was a lot of pain. That was the worst injury I've ever had to deal with. Okay, immobilization. That reduces the mechanical stress. What does that mean? Well, to me, it induces a mechanical injury because the material properties are going to deteriorate. Plaster, fiberglass casts, weaken the bone, reduce the stiffness, decrease the toughness. It's a mechanical injury. Immobilization takes 6 months to a year to recover from. And then if you add in an injury, it takes even longer. So we don't like to cast. I know physicians still do that in children, but they're trying to make sure that that bone is not re-injured. They look at a 10 or 12-year-old like, I don't trust you. I'm going to put a plaster cast on you and make sure that bone is healed before I'll let you out. So here's what happens with 6 to 8 weeks of immobilization. This is our stress strain curves, and we have a pair for comparison. If we look at the slope of the line, we can see there's a huge decrease in mechanical stiffness. Stiffness is way down as the slope of the line decreases. Mechanical strength is down. There isn't actually that much of a change in ductility, so the bones don't really get any more brittle. But if you look at the area under the curve, wow, toughness, energy absorption, it's way, way, way down. So reduce stiffness and reduce strength, reduce the toughness, make that bone more likely to get injured. So you do have to be careful after getting out of a cast or immobilized, because any bones that are in the region are susceptible to injury. And this is why you got to go through really good rehabilitation, because you've got to reattain those mechanical or material properties, especially if they put you in a cast for whatever reason. Now, the good news is a soft cast like this, there's going to be much less of an effect than there is with a plaster cast. Believe it or not, even those range of motion exercises that you'll do after we're fairly certain the bone is forming a union again, those range of motion exercises will greatly reduce this effect. So immobilization, casting, we'll try to avoid that when we can. Okay, so alternatives. Here we go, sorry about that. Air cast boots, slings, supports, anything is better than plaster. So plaster cast, I can't, I was gonna write in there. Plaster is disaster. Osteoporosis. So this is disease that happens when bone mass decreases to a critical point. It's technically or quantitatively 3 standard deviations below the mean of a healthy young bone. What we see with osteoporosis is more porosity, more pores, if you will, in cancellous bone. Cancellous bone is far more affected than cortical bone. So whether it's in the spine, and here we're talking about the upper thoracic region and the lower thoracic region. Notice you have the big curves right in here. And that means that there's more susceptibility to shear forces in those two parts of the spine because they're not directly up and down. Human spine can deal with compression and torsion, doesn't deal with shear nearly as well. So the shear forces over time can cause fractures in the thoracic vertebrae, and especially in the anterior portion of the thoracic vertebrae. So a person can actually lose height and get this dowager's hump. So that's what we're trying to do, is we're maintain healthy trabeculi. This is where exercise training becomes incredibly important, as well as good diet throughout the lifespan. What we're trying to do is reduce osteopenia, first of all, and then reduce the risk of osteoporosis. So with primary prevention, if we can increase bone mass, maintain it or enhance it over adulthood, that means we should have more during the treatment and during prevention later in life. So we hope to be able to prevent a lot of these types of fractures. They look familiar because they're usually associated with aging, but it's really a combination of aging, hormonal changes, and sedentary lifestyle. Thoracic vertebrae, that can cause dowager's hump, distal radius, often that happens with a fall, or the neck of the femur, that's a hip fracture. When there's a fall with a hip fracture, about 50% of the time the fall causes the fracture, 50% of the time the fracture causes the fall. So there we see, unfortunately, dowager's hump again. Again, we want to be able to avoid this. It's affecting over 10 million Americans, over $17 billion annually. Those numbers are probably a little low now, I hate to say. These could triple by 2060. About a third of all women and 17% of men will suffer a hip fracture by age 90. 12 to 20% are going to have some complications. Blood clots, they could cause an embolism in the lung, that could cause a cardiac problem. If there's underlying cardiac disease or risk of pneumonia, then that also puts a person at risk. So osteoporosis, also because it involves chronic inflammation, might put a person at risk with COVID. So that's something I was thinking about. There's a lot of interaction between the types of genes and proteins. With COVID, the virus focuses on an enzyme called angiotensin converting enzyme in the lung. It's a special type. It's called ACE2. This ACE2 is actually protective, but unfortunately, the virus basically grabs that protein, uses it for its own needs, which is to replicate itself. So it's going to replicate its RNA and its proteins. It's going to hijack it. And that means ACE2 is down. When ACE2 is down, angiotensin converting enzyme 1, that increases the levels of angiotensin 2. And so that's why people with high blood pressure, cardiovascular disease, obesity, metabolic disease, as well as, asthma, etc., are at risk with this disease. So some of the medicines they're looking at now will either enhance ACE2 or reduce ACE1. So there's a high blood pressure medicine called lisinopril that does that. So that's, I think, in clinical trials. We'll see how that goes. As you know, there's a lot of stuff in clinical trials right now. Don't wait for certain people to post it on Twitter to see whether it's working or not. Hopefully the science will win, but it's going to take some time. The good news is we've been able to fast track a lot of stuff into clinical trials, and fingers crossed we'll have some good results soon. Okay, risk factors. Family history, ethnic background can place a person at high risk. Best way to think about it, does my aunt or even uncle, grandmother, etc., have they had bone fractures when they were older? Have they have osteoporosis, dowager's hump, etc.? That's puts a person at risk. Women are more susceptible to men. They don't build quite as much bone mass, even though they could. And the other thing is that after menopause, when estrogen levels drop, women become very susceptible to bone mass loss. So just for women, that's what we have here. Amenorrhea means a cessation of the menstrual cycle. That puts a person at risk because you lose bone mass in your 20s and 30s and 40s instead of in your 60s and 70s, and that puts you at risk when you get to be that age. Um, Early menopause, believe it or not, and this is not a reason to have a baby or two or three or whatever, but having babies, believe it or not, is protective. And the reason that that works is the last 2 trimesters, the last 6 months of pregnancy, estrogen levels go way up. Plus, you gain some weight. That combination of gain weight or mechanical stress and estrogen, you get these huge increases in osteoblast activity, and osteoclast activity goes down. And that means bones get thicker in the spine, in the lower extremities. It's even systemic. So sometimes a woman after having a baby or two won't be able to fit their jewelry back on. A lot of times they think it's edema, but it's not. It's actually the bones have gotten thicker. So they may have to get it resized. It's kind of an interesting thing. Age, of course, is a risk factor, especially after age 50. Either being underweight or overweight is a risk factor in increasing the number of fractures. Physical activity, either extreme, sedentary lifestyle or overtraining. Smoking, low calcium intake, low vitamin D intake, or getting enough sun. Soft drink intake, some of that is replacement, meaning you're replacing milk with beverages that are low in calcium. Colas can interfere because they have a lot of potassium. The potassium by itself, and let's see, the phosphate. The phosphate can actually interfere with calcium intake, but it has to be pretty high levels. But that can happen in the summer. 2-liter bottle of Coke in the summer, Diet Coke or whatever, it can happen. It's hot here. Fiber intake. If it is insoluble fiber and it's really high, right now it's hard to find enough salad stuff out there to eat 3 salads a day to put yourself at high risk. Alcohol intake, caffeine intake. Caffeine intake about 350 to 450 milligrams a day will do that. That's about 3 cups of coffee. So it takes a fair amount of caffeine to do that. Just a Coke or a green tea, there's not enough caffeine to really worry about it. And either due to disruption in the menstrual cycle or menopause, low estrogen levels put a person at higher risk. Low parathyroid hormone levels do as well because they help to activate vitamin D. So the next thing we're going to talk about is something unique. It's called the female athlete triad. It was discovered by Chris Kahn in around 1982-83. He published a paper in I think early 1984 or 83. And then Barbara Drinkwater started publishing right after that. So Chris Kahn was actually working for NASA, and he was collaborating with, believe it or not, some people from Moscow. And they were looking at losses in bone mass with these long Russian missions. They were 12 to 18 spaceflight missions on the Mir spacecraft. And so they would stay out there for a long, long time. What they noticed, if someone was out there for a year or more, they lost a significant amount of cancellous bone mass, about 1% for every 1 to 2% for every month. For someone after menopause or after age 55, you're going to lose 1 to maybe 2% of cancellous bone for every year. So believe it or not, it's like almost like a rapid aging. It's not the same mechanisms exactly. Some of them overlap, but nonetheless, it's very rapid loss in cancellous bone. And if they'd been out there a year, they didn't recover. So Chris Kahn was looking at athletes because he figured, well, space flight reduces the loading. So these athletes have lots of loads, whether they're gymnasts or runners or what have you, they should have really high bone mass. And most of the athletes did. But he was looking at a certain group of female athletes, some of the gymnasts and some of the runners who were losing weight, trying to, because there's in their sports, if you have low body mass, that can potentially help performance through a number of mechanisms, number of reasons. And they're trying to make sure they have as little body fat as possible. But what that did in some of those young women was to shut down the menstrual cycle. And when that happened, they started to lose bone mass. So Chris Can started to find some young women in their 20s that had the bone mass of a 60-year-old or 70-year-old. And they brought him to a meeting at the um, um, U.S. Olympic Committee site, which I believe was, there was only one back then, so it had to be in Colorado Springs. There's now one in San Diego as well, because in Colorado Springs you're at altitude. So if you're an endurance runner, you actually detrain at altitude. Um, um, this is where doing a lecture remote is kind of difficult, because that's something we could talk about, but I better stick to the subject matter. Um, so they brought him up to a meeting at the U.S. Olympic Committee in Colorado Springs. And Barbara Drinkwater was there, and she said, "We came to crucify," because they said there's no way that exercise could be bad for bones. But she went back, she looked at his data, she went back to her laboratory, and then found some of these athletes indeed had low levels of bone mass. So she published a paper within about a year in the New England Journal of Medicine, and she actually named it the female athlete triad. And it's usually osteopenia that is unexpected in this population. Usually with exercise, these athletes, they have higher bone mass instead of lower bone mass. And it can occur in a significant percentage of the population, anywhere between 10 to 40% of female athletes, most common in runners, gymnasts, aerobics instructors, and it's associated with disruption of the menstrual cycle. But in the female athlete triad, the cause, the thing that does it, is caloric restriction, meaning that in some of these athletes, they might be expending 3,000, 4,000 calories or more during the day, but only taking in 2,000 or 1,500. That gap, that's the gap that does it. So what it does is starts turning off that menstrual cycle. The low levels of the insufficient calories and insufficient protein levels that they're usually taking in, and low levels of calcium, are also enhancing the effect. And you start to see a reduction in, it's mostly cancellous bone mass, because cancellous bone mass turns over faster in terms of protein. So here's that female athlete triad. The threshold's about 30 kilocalories, or big C calories, per kilogram of lean body mass. And we think of it like an eating disorder today that causes amenorrhea and leads to osteoporosis. So some menstrual cycle definitions, if you're not familiar with them: eumenorrhea means 10 to 13 cycles per year, the normal. Oligomenorrhea is 3 to 6. Amenorrhea is fewer than 3, and oftentimes none. So a lot of times people would think about this as an advantage, but unfortunately, in terms of bones and your immune system, it turns out not to be the case. So this is some data from, might have been from Jack Wilmore's group. He used to be here at Texas A&M, TU before that, Arizona before that, if I remember correctly. So usually athletes will have higher bone mineral density than sedentary normal college age population. It was some of these amenorrheic athletes that had the low bone mass. So the cause, again, we think is just insufficient caloric intake. So there's a study done at the University of Florida, and they found in the endurance runners, the men were taking in about 4,000 calories a day, and the women were only taking in 2,000 calories or less. And they weren't much different in size. The men probably weighed about 145 pounds on average, and the women maybe about 120, 115 or so. So the difference, we think, is basically not eating enough. So whether it's an athlete or whether it's an untrained person, amenorrhea causes bone mineral content to decrease. So we think of it today as an eating disorder. So Barbara Drinkwater did a lot of work on this, and there's been a number of other people who've done really good work. She got an award at the American College of Sports Medicine meeting. If we can address the nutrition and low caloric intake, then the low percent body fat issues are addressed and normal menstrual cycle resumes. So that's our intervention, is basically through education, making sure people have enough calories during the day. A 1 or better yet 3-day dietary recall, which you can get your local nutritionist, registered dietitian and nutritionist to help you. There are computer programs for this as well. Maintaining that energy intake. So for college age people, things have gotten better. There have been studies done with the gymnasts in the SEC. So now that we're in the SEC, you probably notice there's a lot of gymnastics everywhere except A&M. Missouri has it. Alabama has it. LSU has it, et cetera. So hopefully someday we'll get it. Maybe our football team is better. We'll have enough money. Because I'd really like to see the gymnastics here, partly because Houston and San Antonio are hotbeds for gymnastics. Bella Caroli used to be down, I think, in the San Antonio area. So we've got this. This would be a great area. A&M would have a great gymnastics team. It would be really cool. And for us in biomechanics, it would be really nice because we could do some filming. There's all kinds of stuff we could do. So things have improved, but it's really maintaining and looking at the menstrual cycle and your diet. So with prevention, promoting bone acquisition, peak bone mass, and secondary prevention, which is building or maintaining bone mass in adults, that's where it's at. So in terms of intervention for osteoporosis, hold on, I made a mistake. All right, sorry about that. Hit the wrong button. We're back. So intervening for osteoporosis, exercise, one of the most important things in terms of prevention and treatment. Both weight bearing and weight training exercises turn out to be the best. Water aerobics is great, but it really doesn't help in terms of osteoporosis, good cardiovascular wise. So if your joints or the joints of people that are exercising aren't really good enough for weight bearing exercise or tennis or jogging or even just walking, then weight training is possible, and it makes a big difference, and you don't have to spend as much time doing the weight training. So that's really good. In intervention, nutrition and calcium supplementation are really important. Watch out for yo-yo diets. You get a vicious cycle because the body protects the fat and starts using lean protein and also glycogen. So you can lose a lot of weight the first week of a severe diet where you're taking in maybe 500 calories and you need 2,000 to 2,200 calories a day. But you'll lose a lot of mass because the body's going to try to preserve glucose. Your brain, remember, needs glucose, lactate, ketone bodies. It's the only thing it can live off of. Ideally, glucose and lactate are the best types of fuels for them. Ketone bodies cause some issues. So those keto diets, they should only be done under a physician's supervision. They are not easy to do. They potentially can cause insulin resistance. So I can't really recommend them. Plus, your body tells you what is going to happen. And that is in the first week, when you start cleaving glycogen, you have a few kilograms in the body, 2 or 3. They're in the liver and in the muscles. You'll start cleaving off water molecules as you split up glycogen. You basically cleave it by disaccharides, meaning 2 sugar molecules put together. When you do that, you release water. So you're going to pee out a lot of weight the first week or 2. And part of it is going to be you're going to go after amino acid storage, because that's how your body's going to make energy, because you're going to assume your things are starving. It looks like there's a famine out there. The corn's not coming in. The wheat's not coming in. The beans aren't coming in. We're having a hard time catching or raising animals or catching animals for meat, or fishing's not going too well. So the human genome is kind of used to, it's regulated or adapted to environments where you need some fasting because there isn't a lot of food available. When that happens, what you're going to do is you're going to go after the amino acid storage and the carbohydrate storage first. So the amino acid storage means you're going to go after muscles and bones, your lean mass, to make amino acids. And those amino acids in the liver are going to be converted by gluconeogenesis to glucose for the brain. So remember, the brain is going to be number one. You got to get glucose. You're going to get it where you can. If it's not coming in the diet, you're going to try to get it somewhere else. You're going to try to get it somewhere else. Okay, hormone replacement. Estrogen replacement was used for a while, but the problem with that is even though the type of estrogen you get is mostly estrone as opposed to estradiol, it doesn't quite have the risk factor for cancer, but cancer is a risk factor in some individuals. And it also potentially can lead to, believe it or not, heart attacks because it decreases blood clotting time. So instead, we have what I call designer estrogens like raloxifene and Vista. That was fairly popular because it reduced bone fractures and it actually decreased cancer risk. It's expensive and it's not used as much as it used to be. We also used to use calcitonin and parathyroid hormone. Calcitonin was done in a spray, and I think parathyroid hormone, it's a peptide, it had to be given by injection. Today, what we try to do instead is inhibit this pathway that activates osteoclasts. Osteoclasts sometimes can come from progenitor cells that resemble or even are macrophages. I told you they were cousins of macrophages. So the more osteoclasts we have, the greater the bone mass loss and the greater the risk of osteoporosis. So we use bisphosphonates and also an antibody. So this is a biological, an antibody that is specific for rank L. Rank L is a transcription factor. Transcription factor, remember, is a protein that binds to the promoter region of a gene and either turns it on or off. In this case, rank L is going to turn on NADPH oxidases like NOX2. And when that gets out of the Goldilocks zone, it's going to crank out a lot of hydrogen peroxide. It's not just for bleaching hair anymore. That's going to activate the osteoclast too much. So what we're going to do is we're going to try to inhibit NOx 1, 2, and 4, inhibit rank L. So bisphosphonates, Fosamax, Beniva, for example, that's the way they work. They're actually similar to statins in chemical structure, but they inhibit these NOx chemicals, these NOx enzymes. Believe it or not, statins also do this. And that, I think, it's actually a side effect of the drug. And that, I think, is actually the primary mechanism by which I think statins reduce cardiovascular disease. I don't think it's by reducing cholesterol. Cholesterol isn't bad for you. It's only when cholesterol gets oxidized. And these are the puppies that can oxidize the cholesterol. So you can also go to rank L. You're basically like turning off the spigot, and you're going to reduce osteoclast formation. So Prolia has become pretty popular, and it works directly on rank L. So once you inhibit rank L, you don't get this rise in NOx 1, 2, and 4. You don't get as much hydrogen peroxide, and you reduce the amount of osteoclast production and osteoclast activity. One of the keys to remember, and this is going to get into the last part of our discussion, which we're actually going to finish next week. It's about exercise, and it's about Wolff's Law, basically bones remodeling according to functional demands. When you combine exercise with these therapies, and this is from a while ago, this was done at the University of Florida, where they had people using weightlifting machines, Nautilus machines technically, and combining them with hormonal therapy. And when you combine them, you got this huge effect that you never see with exercise alone, and you don't see with hormonal therapy or another type of therapy including Prolia. alone, it just doesn't do it. But when you combine them, you see this huge effect, 8% over 12 months. I've almost never see anything like this. That's about 20% increase in bone strength. That's huge, huge. So that's really encouraging. So next week, we're going to finish up by talking about Wolff's Law. Wolff's Law was not tested in our environment until the 1960s. And we got interested because we found that astronauts were starting to lose bone mass in space flight, and then people who exercise more. So this reminds us of a classic study that was done with double-decker buses, and the conductor versus the driver. The drivers were often obese, or they had cardiovascular disease and or metabolic disease like type 2 diabetes. The conductors walk up and down the stairs all day long collecting tickets. So because they were physically active, their health outcomes were a lot better. They lived longer, they didn't have chronic disease. So exercise clearly is good for us in a number of different situations. If we remove loading and reduce exercise, that happens with space flight, and astronauts now exercise 2.5 hours a day, and that's too long. Not because of the benefits, because it just takes up so much time and they have other things to do. So they're trying to figure out how can we reduce the time but get better benefits, because the exercise in space, it's really difficult. It doesn't always work that well, but right now it's better than nothing. So with space flight, people can lose a lot of muscle and bone mass. It can be 1 to 2% of bone mass per year. Here's the good news: you get taller in space. Your vertebral discs swell. They actually get more water content, but that's actually not a good thing, because when they come back into a gravitational environment, you lose that height, and the vertebral discs have problems for, it looks like, years afterwards. So the Mir missions and Soyuz missions, that's where we got a lot of the initial bone mass data. That's what Chris Kahn was investigating when he accidentally discovered the female athlete triad. He didn't give it a name. Barbara Drinkwater gave it a name the next year. So when we come back next week, we're going to talk about Wolff's Law and compare it to, and talk about protecting bone mass against osteoporosis, osteopenia, enhancing bone mass with exercise, also exercise during rehabilitation. So it'll be about Wolff's Law. That won't take very long. And then we'll start talking about tendon and ligament biomechanics. That will be the thrust of next week's discussion. And then the following week, on that Monday and Tuesday, I'll have 2 short-ish discussions about cartilage and arthritis. So it looks like we're in good shape. I got a meeting right now, so I have to stop anyway. And over the next 5 or 6 hours, I actually have to do some repairs in a bathroom. We've got some water issues in a bathroom. And then I'm checking over my mock exam to make sure that's working. So it looks like we're going to be using, again, eCampus for the exam. I'm going to upload a Word document that will contain the exam. You download it. You guys are going to type on it and then upload it back. And I'm going to look at the ability either on my exam, or you guys either drawing or writing any figures and uploading them as pictures and attaching them to your exam. So we're going to figure out how that works over the next few hours or so. Or it looks like I've done a little bit of practice. It looks like it's going to work, but I'm going to do a mock exam and make sure it does. Okay. Have a great afternoon, great rest of the week. Good luck on the exam tomorrow. That'll be on Wednesday. I'm going to be posting these here really shortly. Okay, if you have any questions, just feel free to email me. We'll see you very soon. Bye-bye.